information regarding chronic liver disease to practitioners around the country. And when I received this invitation, there was a list of speakers that were available to come, and one of those was Dr. Mitchell Shiffman from the Liver Institute of Virginia, and I jumped at the chance to be able to invite Dr. Shiffman to come to speak to us today. I first heard Dr. Shiffman about 9 years ago at one of the board review sessions for gastroenterology and preparing for my certifying exam in gastroenterology, and found him to be one of the best speakers that I've heard over the years in any topic in liver disease. And so I have thoroughly enjoyed listening to him discuss liver disease. And in fact, about 2 years ago, I attended the ACG Hepatitis School, which is a program of the American College of Gastroenterology devoted to training practitioners in viral hepatitis treatments, where he helped to organize that initiative with the college. And so it's my pleasure today to introduce Dr. Shiffman from the Liver Institute of Virginia. He's going to come and speak today about hepatic encephalopathy and long-term complications of cirrhosis. And without further ado, I'm going to give it to him. I must interrupt one thing. He does have one thing that he mentioned to me last night and heard before. This is a gentleman who grew up in New York, and he attended Woodstock. So, Dr. Shiffman.
Well, thanks so much. That was a very nice introduction. Yes, I was only 13 years old when Woodstock was 2 miles from my house in 1969. If I was 18, I'd probably have Hep C. Okay, so we're going to be talking about cirrhosis, complications of cirrhosis, and particularly hepatic encephalopathy, and how to manage that both in the hospital as well as to keep your patients out of the hospital. Okay. So this, as Dr. Morris mentioned, this program was put together by Chronic Liver Disease Foundation. And yeah, they're really an excellent group that has a board of directors, including his mentor, Dr. Ballard, from down in New Orleans, and other prominent hepatologists and associate people that specialize in different disease states. So they do a really excellent job every year. A group of faculty gets together, looks at all the data on different topics, and puts together different lectures like this. These are my conflict of interest. We do lots of different clinical trials with lots of different companies and lots of different liver diseases at our Liver Institute in Virginia. And I'm also an advisor and consultant to several companies. So what we're going to be talking about is we're going to talk about recognizing the signs and complications of cirrhosis and why it's important to intervene. We're going to look at patient management strategies, particularly as it relates to hepatic encephalopathy, both in the hospital to get the patient out of the hospital faster, as well as the outpatient setting to try to prevent readmissions. And then we're going to talk about other patient management strategies for hepatic encephalopathy. Now, cirrhosis is a very common disorder. It's really not known how many people are out there with cirrhosis worldwide or in the United States. And the reason for this is most compensated cirrhosis is very silent. You can have Child's class A cirrhosis, so you can have a scarred liver, but the liver enzymes can be normal, the liver function can be normal, and sometimes the signs that that patient has cirrhosis can be very subtle. However, on the best estimates, it's about 1% of the population, or 3 million individuals in the United States, that have cirrhosis of various causes. Now, we already mentioned that the vast majority of these patients are asymptomatic. And for me, one of the most subtle features that you can pick up when you see a patient is thrombocytopenia. Okay, the most common cause of thrombocytopenia out there in the community, particularly when the hemoglobin and the white count is normal and it's obvious that the patient doesn't have leukemia, the most common cause of thrombocytopenia is cirrhosis. And if you keep that in the back of your mind, you're going to make the diagnosis of cirrhosis in many asymptomatic individuals. Usually what it would require at that point is some imaging of the liver and maybe an endoscopic procedure, because most people with thrombocytopenia will have some degree of portal hypertension, either varices or portal gastropathy. Muscle wasting I kind of think of as more of a manifestation of end-stage liver disease, but a lot of people can have subtle muscle wasting and weakness, particularly some thinning of the temples, even with early cirrhosis when the liver function is still relatively normal. And maybe the albumin in those patients will be lower limit of normal or just slightly low. We tend to think of the AST and ALT ratio as a sign of alcoholic liver disease. And however, for almost all liver disorders, hepatitis C, fatty liver disease, hepatitis B, immune liver disorders, the ALT is always greater than AST until you get cirrhosis. And once you get cirrhosis, that ratio flips around and AST becomes greater than ALT. Now, it's not the 2-to-1 that you're used to talking about or used to seeing or used to pointing out in a patient with alcoholic liver disease, where the AST may be 100 and the ALT may be 40, but it's more of a slight increase in AST, maybe 55 AST, 50 ALT. If you have that plus thrombocytopenia, 90% of those patients are going to have cirrhosis of the liver. In addition, the liver enzymes can be normal or may not be abnormal, kind of a double negative, but can be normal in many, many patients with cirrhosis, particularly what's going to become the most common cause of cirrhosis over the next decade, which is fatty liver disease. And the reason for that is that once you develop cirrhosis from fatty liver disease, for some reason the fat tends to dissipate. It dissolves, it goes away. The liver can't continue to make fat and store fat in a cirrhotic liver. And so the vast majority of patients with cirrhosis who acquired that cirrhosis from fatty liver disease, if you then biopsy them after they have cirrhosis, they have no fat. And we call that cryptogenic cirrhosis, but they have all of the features of metabolic syndrome, and we say presumably they had cirrhosis from fatty liver disease. But what happens when that fat all goes away is those liver enzymes, which used to be mildly elevated, come down to normal. And we see that all the time, very, very common. Other etiologies can be a history of alcohol abuse in the past. Maybe a patient was a heavy alcohol abuser for most of their adult life, but now you see them in their kind of later in life, maybe in their 60s or approaching 70 years old, and they have normal liver enzymes, some thrombocytopenia, but that history of alcohol in the past may have been what caused them to develop cirrhosis years ago. And of course, uncontrolled diabetes and obesity related to metabolic syndrome. Now, this is a graph from Dr. Aminco from the Barcelona liver group. And this is one of the most prominent liver groups in the world in Barcelona. And basically, they have got lots of data. They made lots of contributions to the literature. And this is one study they did where they took a lot of people, 806 people, with stable cirrhosis. And then they followed them prospectively over time. And what you can see is that about 5 years, which is about right here, after about 5 years, 50% of your people with stable cirrhosis will have developed decompensation. Decompensation is development of ascites, variceal bleeding, or hepatic encephalopathy, or liver cancer, a decompensation episode, 50% in 5 years. So if you're following a patient with cirrhosis in your clinic and they're stable, okay, they're eventually going to decompensate. That is the natural history of the disease. Now, these decompensation episodes, as we mentioned, encephalopathy, ascites, and hemorrhage, but other things that can happen include once a patient has ascites, they can get SBP. Once a patient has ascites, they can also develop hepatic hydrothorax. Once a patient has ascites and acute kidney injury, they can then progress to hepatorenal syndrome, although that's usually going to be precipitated by a further complication, such as infection, primarily sepsis or SBP. Rarer complications include pulmonary hypertension as a result of cirrhosis, as well as shunting, portal pulmonary, hepatopulmonary syndrome, and liver cancer. Many patients with cirrhosis develop portal vein thrombosis. Frequently, this is an asymptomatic event, and it's found incidentally. And in most, if you ask most hepatologists, they would not anticoagulate that patient, where a portal vein thrombosis was identified incidentally without any symptoms. However, if a patient comes into the emergency room and with abdominal pain and is now found to have portal vein thrombosis, that portal vein thrombosis may be the cause of that pain because it may be acute, causing acute portal hypertension, some mesenteric ischemia, and that would be an indication for anticoagulation, at least for a period of time. And generally what we would do is we'd monitor that patient for 6 months, and if the clot doesn't resolve in 6 months, we would simply stop, and that probably wasn't the cause of the pain. Now, we're going to be talking mostly about many issues related to hepatic encephalopathy for the purposes of this lecture. We're going to talk about the scalings, the scoring system, the definitions of HE. We're going to talk about its economic and social burden to society. We're going to talk about hospital admissions and readmissions and how to get the patients out of the hospital quicker and prevent readmissions with effective therapy. And finally, we're going to finish up by talking about what HE does to cognition, not just in the acute event when the patient is encephalopathic and confused, but what hepatic encephalopathy may do chronically long-term to permanently impair cognition in patients that are affected. So our treatment goals for overt hepatic encephalopathy. So overt hepatic encephalopathy is encephalopathy that is obvious. The patient is confused. They may be slightly confused, just a little bit disoriented, problems with some dates. You can recognize this when you're talking to a patient. They just look like they have to concentrate really hard to express what they want to say. A lot of times, hepatic encephalopathy is caused by a precipitating factor. That factor can be infection, GI bleeding, or dehydration. Don't overestimate dehydration. It occurs a lot as a precipitating cause. And one of the reasons that encephalopathy resolves so quickly when patients are hospitalized is because you're rehydrating them. They get IV fluids, that brings down the ammonia, and they wake up very, very quickly. And they were probably taking their lactulose and other medicines, but they just got dehydrated from the lactulose. And I'll kind of come back to that again, because lactulose, while it's a good treatment for HE, may also be a stimulating factor of HE if you give too much. Another focus of the treatment of HE is to reduce the nitrogen load that's coming from the gut. We want to correct electrolyte abnormalities if they're there. And we want to, most importantly, assess for long-term therapy to try to prevent another occurrence. So I've seen many, many patients that are admitted to the hospital for hepatic encephalopathy. They were on lactulose when they came in the hospital, and they go home on the same exact dose of lactulose that they came in on, and guess what? You know, eventually they're readmitted because nobody did anything to step up their therapy to prevent further episodes. So we've got to focus on what are the precipitating factors that cause this hepatic encephalopathy and try to control or prevent them. We want to reduce the likelihood they're going to get another encephalopathic episode. And clearly, if the patient is experiencing encephalopathic episodes, we want to understand, are they a candidate for liver transplantation because their liver function is deteriorating. So this lists a couple of different medications which are widely utilized for the treatment of hepatic encephalopathy. And really the mainstay that you're all well familiar with is lactulose. This is a poorly absorbed disaccharide, and what happens is you drink this liquid. It tastes real sweet, but it doesn't increase your blood sugar because the disaccharides are non-absorbable, and they're not really glucose anyway. And what it does then is as it goes down and enters the colon, it is then, this disaccharide is metabolized by intestinal bacteria. It's cleaved, and it increases the osmolality of the stool. It sucks in water and creates this cathartic effect as a result of that. In addition, the disaccharides are broken down by intestinal bacteria to acids, and that acidifies the stool and thereby traps ammonia, converting it to ammonium, NH3 to NH4, in the stool and reducing plasma ammonia levels. It's been around for a long, long time. It was actually approved in the days before you needed randomized controlled trials, and there were very, very few patients enrolled in the original study of lactulose for treatment of HE. I think there were only 12 patients in the study. I went back and found the original article, made a slide of it. But almost all of them responded with a drop in the ammonia level and improvement in cognition. Now, our second-line therapy today is a drug called rifaximin. And rifaximin is a non-aminoglycoside semi-synthetic antibiotic. It's non-absorbable. It doesn't get out of the intestinal tract, and therefore it's much, much safer than neomycin, which we used to use when I was training as a resident and early fellow before rifaximin was available. And what rifaximin does, being an antibiotic, it really eradicates and kills off the bulk of the colonic bacteria, sterilizing the colon. And therefore, if it's no bacteria, that bacteria can't make more ammonia by breaking down protein products. Neomycin, metronidazole, and vancomycin all work the same way by killing off intestinal bacteria and reducing ammonia production from the colon. In fact, most of the ammonia that's produced is from bacteria in the colon breaking down protein products that get all the way down to the colon, and ammonia is a product of that. That ammonia then transmits across the colonic mucosa into the bloodstream. The liver can't break that ammonia down because it's cirrhotic. There's portal hypertension. There's shunting around the liver, and as a result, ammonia goes up. But the bulk of the ammonia that's in any of your patients with HE, and in any of you that just ate the turkey sandwich in about an hour, it's going to be from the intestine breaking down those protein products. So all of these work the same way by killing off the intestinal bacteria, but all of these other antibiotics have problems that are not associated with rifaximin. For example, neomycin. Neomycin is the most toxic of all of the aminoglycosides. It causes significant renal toxicity. It causes significant ototoxicity. It's used a lot in surgery to cleanse, prior to intestinal and colonic surgery, to cleanse the intestines. Very, very effective. And in a healthy individual being prepped for surgery, doesn't get out of the colon. However, in a patient with cirrhosis and portal hypertension, where the colonic mucosa can become boggy, swollen, and the tight junctions between those cells now become loose as a result of that, a little bit of that neomycin can leak out of the colon, and because it's so nephrotoxic, precipitate acute kidney injury, and then that can lead on to hepatorenal syndrome and other problems. And I've had patients unfortunately die as a result of that. And the last time I used it was a patient I couldn't get rifaximin for because of poor insurance coverage. He was very, very encephalopathic. He needed something. He could not tolerate Flagyl, which I used for years and years before rifaximin was available. but he was starting to develop one of the side effects of metronidazole that you're all familiar with, which is that metallic taste and some neuropathy. So we just bit the bullet. We used neomycin. He got acute renal injury. It went on to CKD. He went on to dialysis, and he died a month later. And I think that was all the result of giving him neomycin. So most of us will never use neomycin in a cirrhotic anymore. I still occasionally will use Flagyl. It's very good, and if they can tolerate it without the neurologic effects, the paresthesias, or the metallic taste, very, very effective, but clearly not as well tolerated as Xifaxan. So lactulose is really the mainstay of therapy. It's clearly first line. It's cheap. It's effective in 70 to 80% of patients with acute HE. And we've already mentioned its mechanism of action, which it's fermented in the colon. It's broken apart. It creates extra osmotic species. It creates diarrhea. It acidifies the pH and traps the ammonia there. The average dose is about 45 to 90 grams a day. Generally, I like to give it as an outpatient no more than twice a day, and you really do not want to push lactulose as an outpatient for the patient to have diarrhea. Now, if your patient comes in totally confused, what do? We give them lactulose, 45 mLs TID, because we want them to have diarrhea acutely to flush everything out, to flush out the ammonia, to acidify the stool. Okay? However, when the patient goes home, you don't want them to continue to have diarrhea and watery stools from lactulose. Why? Because they're eventually going to get dehydrated. And despite lactulose therapy, they're going to develop acute kidney injury as a result of that dehydration, and that's going to precipitate another episode of hepatic encephalopathy. And I see this all the time by hospitalists and other individuals that, you know, they start the patient on heavy dose lactulose in the hospital. They just keep it on. They go home. And they come right back within a couple of weeks with dehydration. So when the patient gets discharged, you want to cut back to a dose of lactulose that's tolerable, maybe 1-2 bowel movements a day. You want them soft, semi-formed, but you don't want them to have a mess every day with watery diarrhea. So rifaximin is minimally absorbed, oral antibiotic. Only 0.4% is absorbed. It's got a broad spectrum of activity against aerobic and anaerobic bacteria. No obvious drug interactions have ever been reported because it's really not absorbed and doesn't interact. It's not metabolized in the liver for those reasons. No dosing adjustment is required for any other disorders. You don't need to dose adjust for liver disease, and you do not need to dose adjust for kidney disease. It's the same dose even if your patient is on hemodialysis. And it's approved for the treatment of hepatic encephalopathy as a second-line agent in patients that developed hepatic encephalopathy on lactulose. This is the original data from the original phase 3 clinical trial, which led to the approval of Xifaxan for the treatment of hepatic encephalopathy. 91% of the patients in each arm were receiving lactulose. That was first line. And then they were randomized to receive either rifaximin or placebo. There was about 9% of patients that could not tolerate or refuse to take lactulose. You can see, and this is the proportion of patients without breakthrough. So the patients had, to get into the study, you had to have an acute episode of HE on lactulose, if you could tolerate it, and then you were randomized to rifaximin or placebo to prevent a second episode. And you can see here that rifaximin was significantly better at preventing recurrent hepatic encephalopathy than was lactulose, or the combination of lactulose and rifaximin, better than lactulose alone with placebo. Now, why do we want to treat hepatic encephalopathy better? Because hepatic encephalopathy significantly impacts as an expense to our healthcare system. This is data that looks at hospital discharges due to cirrhosis, and they're clearly increasing. They're increasing for several reasons. One, it's poor management of the complications of cirrhosis leading to readmissions. Number two, it's the result of an increasing burden of patients with cirrhosis from the hepatitis C epidemic, which is continuing to increase during this time span and is not expected to peak. So the number of people with cirrhosis out there are increasing from hepatitis C alone, doesn't include even fatty liver disease yet, and from hepatitis C alone, we're not going to peak cirrhosis until the year 2022. Okay, at which point then it's going to start to come down because of treatment and patients dying off. So we can expect that these costs are going to continue to increase, and you can see that just in the 7 years between 2004 and 2011, healthcare expenditures for cirrhosis alone increased by an average of about $170,000 during that period of time. Now, if you look in utilization and terms of length of stay, okay, and you look here at average charges, which is hospitalized, in this 5-year period between 2005 to 2009, again, you can see average hospital charges increasing from $46,000 to $63,000, which is a significant increase. The number of procedures that patients are getting is going up. The length of stay goes up from 8 to 8.5 days, also significantly increased. So all these healthcare expenditures, particularly from hepatic encephalopathy-related expenditures, are clearly increased. This shows mean number of hospitalizations for a patient treated with lactulose versus treated with lactulose and rifaximin. And you can see that this combination therapy significantly reduces the mean number of hospitalizations for a cohort of 150 patients, down from about 1.6 hospitalizations down to about a half a hospitalization. The mean number of hospital days also significantly increases when you add rifaximin as a treatment to that inpatient hospital stay, down from 7.3 to down to 2.5 days. So you start your lactulose, you push it, you add rifaximin right away, that patient's going to wake up, and you can now get that patient out of the hospital a lot sooner because you're not overdosing them with lactulose and you're not getting AKI and other problems that a heavy dose lactulose will be causing. If you look at total time hospitalized in number of weeks for these patients, the average total time for hepatic encephalopathy in patients treated with lactulose alone, 1.8 weeks, where rifaximin, a half a week. And average hospital charges as a result of all this reduction in hospital utilization is down significantly from $56,000 to $14,000 from this study by Carol Levy. So significant improvements in reduction in hospital stay, out of the hospital quicker, and reduced cost. Now, overall, if you look at the group 1 treated with lactulose, the group 2 treated with rifaximin and lactulose, and you look at the demographics, no real difference in gender distribution, MELD score, age, but simply the number of hospitalizations has significantly gone down. Now, this data looks at different treatments that you can use for hepatic encephalopathy and the impact of these different treatments. So number 1 here is patient was on lactulose as an outpatient. They came into the hospital with hepatic encephalopathy, and you just kept the patient on lactulose. There were 18 such patients. Their MELD score was 11. They stayed in the hospital an average of almost 5.7 days, and their cost was about $48,000. Our next line here, Our next line here is the patient was on rifaximin as an outpatient. They got encephalopathic. They added lactulose during the hospitalization. And their mean length of stay was only 3 days, and therefore reduced cost. Lactulose, then rifaximin was added, also reduced cost. No therapy, lactulose and rifaximin added, high cost. And no therapy, again, lactulose added, the highest cost. So your best cost is when you're adding lactulose to rifaximin or rifaximin to lactulose to get to dual therapy, and that gives you your lowest overall cost and your lowest length of stays. Now, we're in the days of the Affordable Care Act. It may go bankrupt. I'm not taking political sides. But the Affordable Care Act, one of its functions was it wanted to reward hospitals for achieving certain goals. It's buried in that 15,000 pages of documents that there were rewards for hospitals. They got bonuses if they achieved certain goals and reduced cost. And the measures that did that was to reduce 30-day readmission rate. So if you reduced your 30-day readmission rate, you got a goal. You got an extra bonus from Medicare. If you decreased your average length of stay and you decreased your mortality, same thing. These were goals of the ACA to reward hospitals for doing a better job. And there were certain high-priced disorders that they focused on as well. MIs, heart failure, COPD, common things, pneumonia, as well as reducing hospital-acquired conditions. Really, cirrhosis and treatment of hepatic encephalopathy were not one of these, but people with cirrhosis and hepatic encephalopathy frequently have a lot of comorbidities. They frequently have sepsis. They can frequently have pneumonia. They can frequently have UTIs and other things that are part of these measured items. And if by better managing your hepatic encephalopathy, you can reduce 30-day readmissions and reduce the length of stay, your hospital is going to get a bonus as a result of doing that. Now, we've looked at the benefits of treating HE for the hospital and for the cost of medicine in general. What about the patient's family, the patients, the individuals that have to take care of the patient with confusion? Well, for the hepatic encephalopathy caregiver, when you ask them, how does taking care of your loved one, your husband, your wife with cirrhosis complicate your life? They talk about a whole bunch of different things. So the complications of cirrhosis, HE, ascites, bleeding, coagulopathy, nutrition issues, all affect how affect the patient, and they all affect the caregiver who has to take care of that patient at home. It increases the cost to the household, it increases the strain to the care provider, and it increases the amount of time that the care provider has to spend with the patient addressing all these things. The patients have impaired ADLs. They can't dress themselves or care for themselves as well. They have functional disabilities. They can't drive anymore. Somebody has to take them to all their appointments. So if you look at the impact of HE and how this affects the family, and you query them, what you see is it is a financial burden. So half of the households stop being able to save money, either because the patient was a wage earner and is no longer earning wages, or the wage earner now has to take more time off from work to help the patient get to their appointments, because if you're encephalopathic, you can't drive, or at least you're not supposed to drive. And there's a whole bunch of data on the impact of driving, even with mild hepatic encephalopathy. These people have more traffic accidents, more tickets, and when they get into traffic accidents, they have higher mortality than the average traffic accident participant. A lot of families go into debt for all these reasons. There's late bill paying, little food, bankruptcy, and things like that. So increased caregiver burden can be assessed with a caregiver burden inventory, where caregivers are asked a series of questions about how does this family member impact your life? What do you have to do? And if you look at the burden, it significantly increases. If the patient is unimpaired, just with stable cirrhosis, there's really minimal impact to the caregiver. However, in a patient even with minimal encephalopathy who's intermittently confused or subtly confused, right away you can see an increase in the burden to the care provider. And with overt hepatic encephalopathy, a significant, this patient now creates a significant burden to the family. As a result, there's incremental costs that are involved, all-cause hospitalizations avoided by treatment, and if you look at the cost involved, they're significant, and the cost per quality of year of life gained by treating hepatic encephalopathy lifelong is well within the range considered to be cost-effective. So let's look at hospital readmissions now, outpatient treatment of hepatic encephalopathy. So one of the things you want to do is once you identify these patients is you want to make sure they get on a better regimen so they're not constantly readmitted to the hospital. This is a retrospective study, 402 patients from an academic transplant center. And if you look at hospital readmissions, about 15% of the patients who are discharged with a diagnosis of HE are readmitted within a week. About 40% are readmitted within a month. And overall, 70% of the patients eventually get readmitted in a 67-day period of time. The median number of readmissions was 2, 3 hospitalizations per person per year. If you look at all-cause and rehospitalizations specifically related to hepatic encephalopathy, here in this color, I'm colorblind. I think that's red, but I could be way off. And blue, at least dark blue to me. So if you look at all-cause readmissions in the blue, 27% of patients are going to get readmitted with cirrhosis, going to get readmitted within a month, and 17% specifically for encephalopathy. Within 6 months, it's up to 50% and a third respectively, and in a year, it's even higher. Half the patients and almost 40% of the patients are going to get another episode of hepatic encephalopathy. So these are significant readmission rate to these patients because of their underlying chronic cirrhosis, and you want to try to address that and reduce this readmission rate. This looks at the odds ratio over 30 days of readmission, and if you look specifically here at and these are all different complications of liver disease and different liver disorders, you can see, first of all, it doesn't matter what type of liver disorder you have. The adjusted ratio is all about the same. It's close to 1. But for hepatic encephalopathy, 1.6, this is the highest odds ratio for a 30-day hospital readmission, is due to hepatic encephalopathy if you don't do anything to change what you're doing and try to prevent that. This is a 90-day readmission rate, and again, hepatic encephalopathy comes out on the odds ratio as the highest likelihood of causing readmissions, both within 30 days and within 90 days. So reducing 30-day readmissions, you can look for different things and what are the different causes. You can look for one of the causes of hepatic encephalopathy, infections, GI bleeding, symptomatic ascites, but you can see right here that the overwhelming majority of causes is in this control group where we didn't do anything was HE, and when we start to look and use a computerized checklist in the EMR to make sure HE is treated, we can significantly reduce HE as a cause of readmission. This looks at is a univariate analysis of admissions before and during after the addition of rifaximin to the treatment regimen. Before rifaximin, readmissions at 3 months, a 1.17 odds ratio. After rifaximin was instituted, down to 0.74. And length of stay reduced from 15 to 17 days. At 6 months, you see the same thing, 1.6 down to 1. At 12 months, odds ratio of 2 reduced to 1.5. And for all the data annualized, 3 admissions to less than 2. And all of these are statistically significant. So by adding a second-line therapy to the treatment of HE, you're going to reduce readmissions. If you look at the pattern, the mean number of readmissions relative to adding rifaximin, before you added rifaximin, hospital admissions increase. After you've added it, they decrease. Mean length of emergency hospital admissions, before you've added it, go up. After you've added it, go down. So it's pretty simple. So the majority of overt hepatic encephalopathy of patients, unfortunately, they don't receive proper management therapy after discharge. More than 60% of patients did not receive ongoing prophylactic therapy to reduce another episode of HE. So we're just doing the same thing over and over again. And if you want to help that patient, help their family, and help your hospital, you need to address those things. So in one study, HA was one of the most common causes of preventable readmissions within a month. And the ways to do this, to help out, is some of these rehospitalizations could have been prevented by improved patient education, telephone management of the patients, and disease intervention. We're going to finish up by talking about the long-term outcomes and complications of hepatic encephalopathy and what repeated episodes of hepatic encephalopathy can do to a patient. If you look at hepatic encephalopathy, there are definitely changes in the brain which have now been shown on MRI in patients that are encephalopathic. This panel A is healthy control subjects. Panel B is cirrhotic patients without minimal hepatic encephalopathy. And you can see it's pretty similar, lighting up in the brain areas. This is a cirrhotic patient with HE, and you can see that it's without previous overt HE, and again with previous HE, and you can see some differences here. If you look at learning impairment in patients with cirrhosis in a previous episode of hepatic encephalopathy, that without a prior episode, your ability to learn, so if you're evaluated with a test and then you retest it, you learn that test. So what happens is your score, if you look at your hepatic encephalopathy score, it's basically improves on your second evaluation, okay? Meaning that you're learning and you can do this test better. On the other hand, in patients with cirrhosis and prior episodes of HE, there's really not much learning that goes on. You can see that the scores are almost all flat, or they actually go down. They don't get better. So you're not learning because the encephalopathy prevents you from learning that task. The inhibitory control test is a computer-based. You can do it on your cell phone. You can Google it up. It's called a Stroop test. And basically, you can give that to a patient in your office. And basically what it does, the patient has to basically push a button when he sees something different. And basically, they give you a series of similar patterns, and then they give you something different. You're supposed to recognize that. Patients with encephalopathy are slow. They can't process as fast. And so they can't recognize that different pattern when it happens. And as a result, they have significant impairment up here in that test. They make the wrong decisions. If you look at brain volume in patients with a history of HE after liver transplantation. You can see those with hepatic encephalopathy have lower brain volume than those with. Now, this is not the transplant surgeon, okay? This is the patients. No transplant surgeons in the audience. They didn't laugh at that. Okay. So also, the other thing is when you take a patient with hepatic encephalopathy long-standing and you do a liver transplant, and then you measure their cognitive ability, either attention, memory, or executive function. The top line are patients that really didn't have overt hepatic encephalopathy. So they started with better attention, better memory, and better executive function, and after transplant they improved. When you take a patient with hepatic encephalopathy and you test them prior to transplant, their attention, memory, and executive function is significantly lower than the patient that did not have encephalopathy. They improve, and they have a lot more to improve, but even after transplant, they stay reduced compared to the patient that did not have encephalopathy prior to the transplant. So they don't come to normal. They don't normalize up here like a patient would after transplantation. They have permanent brain dysfunction in some areas, or mild impairment, which persists. Again, you can see that here. These are patients who had encephalopathy pre-transplant or versus no encephalopathy pre-transplant. And you can look at immediate memory, visual spatial, language, attention, delayed memory. Overall, across the board, memory function is significantly impaired after transplantation in patients that had impact prior to transplant. This affects a patient's ability to return to the workforce. Returning to the workforce after transplant has dismal results. Overall, less than half of patients that have a liver transplant actually return to the workforce. Now, some of that's social problems because of they lose their job, they get sick, they lose their job, they have to get on Medicare. And you know, once you're on Medicare, if you go back to work, you lose your Medicare. So unless they're in a particularly good working environment that can keep them balanced or is willing to take them back and they get their insurance benefits back right away, as soon as they start working, they have a lot of financial risk of trying to go back to work. And this is really why a lot of patients with HE, why a lot of patients don't go back to work after transplant. But still, a lot of this is due to cognitive impairment and an inability of the patients to do the job that they did prior to the transplant. So, in conclusion, I want you to understand that HE has economic and social implications and burden, particularly for the family, particularly for the hospital setting and the costs involved. And this burden is realized by not just the patients, but their caregivers and your institutions. It's an important cause of hospital readmissions, and we can do a better job by reducing hospital admissions and care for the patients better if we realize that there's second-line therapy that has to be instituted, and it should be instituted as soon as first-line therapy fails. There's a few minutes left for questions. I'd like to thank Dr. Morris again for inviting me to come to Shreveport. It's my first visit. And thank you all for your attention. Yep.
Would you consider the first episode of encephalopathy a failure of first-line therapy? And if so, what should be started and what dose?
The second episode of HE is
The
first episode of HE is due to the natural history of liver disease. Now, if you look at the general ASSE guidelines, we don't want to prophylax against the first episode of HE. We want to look for it. Now, if you're a student, you pick that up in the office, you can prevent a hospitalization by adding that. Because patients, when I see them for cirrhosis follow-up. They do give me this, oh, I'm kind of more forgetful, I'm losing my keys more often, and I'm not listening when my wife talks with me, and it's more than just being married to her for 30 years. Things like that. So there's subtle little clues you can pick up if you listen to what the patient is telling you. And if you put those patients on lactulose, you can probably significantly impact that first episode of HE, although I'm not aware of any data that shows that.
After the first step, no, they're admitted to the hospital with HE.
Yes.
What do we do now?
So if they're admitted to the hospital with HE, a first episode, they're going to be treated with lactulose, and then the first-line treatment would be discharge on lactulose therapy. Now, again, if you see them for follow-up, but you get the sense that they're having too much diarrhea, okay, or they're still a little bit confused on a dose of lactulose that won't give them diarrhea, but is still leaving them somewhat confused, I would add second-line therapy as an outpatient and try to prevent that second hospitalization.
And after the second hospitalization, you would start...
Absolutely. Anybody that's on lactulose, admitted with lactulose, should be on rifaximin at discharge to prevent a second episode. I think the data is very, very clear on that and very strong. Yes?
So like they have in ICU, there are simple screening tools for malaria and any mental status exams. Is there validated screening tools for encephalopathy for the GI practitioner?
The best test is what's called the Stroop test that Dr. Bajaj uses in his practice. Dr. Bajaj, who's in Richmond, used to be one of my colleagues when I was at VCU Medical Center, is really the pioneer in a lot of all of our new, he's really revolutionized the whole new treatment of hepatic encephalopathy again. And our understanding of it. And so he's developed a Stroop test. It's on your app. I think Dr. Morris just pulled it up. And it basically, in 60 seconds, you can get a feel for whether that patient failed that test or passed it. And it just basically recognized delayed cognition and inability to recognize things quickly. So there is a test. Yes, any other questions? Yeah.
So I assume there's a theoretical risk with these antibiotics that you kill the bacterial flora and you have they interfere with vitamin K production. But there's like a clinical correlation is that worse in the coagulopathy, cirrhotics, is there clinical evidence?
No clinical evidence that I'm aware of in Xifaxan with all its experience that you're increasing the INR as a result of vitamin K abnormalities. My understanding is that there's does not increase the risk of C. difficile infection either. In fact, it can be used as a treatment for C. difficile, not first line, but can be used. Any other questions?
Could you discuss the effect of sedating agents in the hospital on these patients?
Oh, yes, yes. Yes, one of the major causes of precipitating encephalopathy in a cirrhotic in the hospitalization is oversedation. In fact, one of the causes that brings patients to the hospital is oversedation. And, in this day where we're also much more wary of narcotics now, and, a lot of these patients, they are on, they complain of pain, they're treated with narcotics, they're on narcotics as an outpatient, and that frequently leads to episodes of hepatic encephalopathy, and as well as benzodiazepines. So I think you have to be very, very cautious in giving these patients benzos for sleep, giving them narcotics for pain. Remember, the best pain agent in a cirrhotic that is not consuming alcohol is acetaminophen. It is the best pain agent. Okay? Acetaminophen does not cause liver injury unless you take 40 pills at a time or unless you're actively consuming alcohol. The vast majority of patients with cirrhosis are no longer consuming alcohol, and therefore acetaminophen is a very, very good pain reliever. In fact, probably better than in a non-cirrhotic, because remember, acetaminophen is broken down in the liver, and if you're cirrhotic, it's actually going to have delayed breakdown, so it's going to be less toxic, because the toxic products of acetaminophen are its breakdown products, and the analgesic properties are the parent drug. So if anything, acetaminophen is a very, very good agent for pain control in cirrhosis and less toxic, as long as they're not drinking alcohol. And generally, for my alcoholic patients, I will wait at least 6 months of sobriety before I'll give them, allow them to take Tylenol to make sure the P450 increase that's proliferated by alcohol has now resolved. In the hospital, it's very easy when you get a call in the middle of the night, patient's up, is restless, give them some Xanax, give them some Ambien, put them to sleep, and the next thing you know, they're encephalopathic the next day. You want to try to avoid that. What I tend to use for sleep in these patients is trazodone or Elavil for their sedation properties, and that will not precipitate HE like a benzo will. Yep?
On the topic of hepatic encephalopathy,
That is the topic.
would you recommend checking zinc levels as like zinc deficiency?
Yeah, you can certainly do that. I think whenever you see a lot of these patients, as they get cirrhosis, they get malnourished, they don't eat well, particularly if they have ascites. And malnutrition becomes a big problem in cirrhosis. That's now a huge topic. In fact, at the annual meeting of the ASSLD, the Liver Society, just last month, the biggest topic was on malnutrition, wasting, and what we call now frailty, which has been studied in lots of different avenues of medicine, particularly geriatrics, that is now starting to be applied for patients with severe wasting weakness as a result of cirrhosis. And frailty turns out to be one of the major indications, malnutrition and frailty turns out to be one of the biggest risk factors in not surviving liver transplant surgery. And so there's now going to be a lot of attention, I think, turned to that, and a lot of good studies being done on frailty and how to combat it. And it's all going to be nutritionally based and physical therapy based. And that's what we need more of in these patients. You got to feed them when they're in the hospital. You got to make sure they get proper nutrients and vitamins. And you've got to get them physical therapy and get them up and moving. The worst thing that happens for a patient that comes in with encephalopathy or complications of cirrhosis, they lay in bed for a week. We give them fluid. They fill up. They get edema that's not properly managed. And you just create a cycle where they go from nursing home to hospital and back and forth. And what happens with each time, they get weaker and weaker, and they're not transplant candidates. And we turn good transplant candidates into bad transplant candidates because of poor management of fluid and nutrition. So yes, checking all vitamins is good. Any other questions? Great. Again, thank you very much. Your hospitality was great. We had a great dinner last night.